comments that you want to highlight in terms of system strengthening? We have probably forgotten what you said, and then I'll let Prof.
I don't really claim to be an expert on much of that, but I certainly can identify with much of what Julie was saying from my experiences in Sierra Leone. Patients with dying of Ebola did experience quite a lot of pain, and we were very proactive with IV paracetamol, and that seemed to go down quite well with the staff. But non-steroidals seem to be contraindicated because of the bleeding issues. And the minute we mentioned morphine, maybe we should give this patient some morphine, that went down really badly with the staff. And, it was like we were, once you mentioned the morphine, you've given up on these patients. And that wasn't necessarily the case, but I very much felt that the palliative care aspect of what we did in the treatment centre was poor. And I think, I feel some remorse about that retrospectively, and not just from hearing Julia, but anyway.
I think I'll open it up for people to make comments and ask specifically. I don't know. I did warn Professor Dambisya that there's an issue that I wanted to raise that I've given forewarning. When you look at, when somebody asked us in one of our groups, is that what is strengthening health services? He says, what is the definition of that? When we struggled a little bit, what I did is I put some core features of the issues that probably you look at in terms of good health systems. And in terms of all the issues that people look at, one of the key issues that we always think is all about poverty. South Africa is a per capita income of about 10,000, but maternal mortality in South Africa is almost 200. Cuba is almost half per capita, but there's maternal much less. So it's not all about money, and we all know that. So there's a lot of issues that are there, which I think we need to remember, which we need to highlight. One of the key issues was about mix of health people and in terms of brain drain. And I think that's what I want Prof to comment. I warned him, I will raise that in terms of, I think we are part of the problem, him and me, because as doctors, we discourage what we think works very well in Africa, of getting clinical officers and a mixture of nurses being promoted to do a large number of work. I trained in Zimbabwe, 80 doctors in my class. There's only 20 left in the country. All of us are overseas. But all the clinical officers that I helped to train are still in the country. Do you want to comment?
Thank you very much, Mr. Chairman. Before I answer your question, I just wanted to say that this conference illustrates how much of a global village we have become. I'm attending this conference because I met up with Dr. Sanfai in Sierra Leone as the Ebola epidemic was waning. And we got talking. I got invited here. I found people who are working kilometers away from my home in Uganda. She's working on a program whose genesis I learned of when I was in Singapore, and Dr. Merriman was starting it up in Uganda. And almost everybody I talked to, so there are so many interconnections. So what you are doing collectively and individually are not isolated incidents. They are all parts of this global effort, and they should contribute to the Sustainable Development Goals where we leave no one behind. The question about clinical officers, non-physician, clinicians, whichever nomenclature you use, has been with us for a long time. In Eastern Africa, it is fairly well settled because the health systems are designed around the clinical officers with specific roles. They run many of the health facilities from health center force downwards and so forth, as she will attest in Uganda. Problems arise in Southern Africa, particularly South Africa, where they are trying to where they have just introduced one. Zimbabwe has been ambivalent on the role of this cadre, and so on and so forth. But I think what has been missing is the engagement which recognizes the gap and designs collectively the strategies to address the gap. Because Malawi, and there's a colleague from Malawi here, to an extent Zambia, have effectively used these cadres. Tanzania, where I'm based at the moment, has also used effectively the clinical officers to deliver surgery, including emergency obstetric surgery, and the outcomes seem to be comparable to what is offered by the doctors. So when there's proper engagement across the professionals, with the understanding of the policymakers that the intent is to address a gap through a properly designed and rolled out program, there shouldn't be that much animosity about it. But then it is always the issue. In Uganda, morphine is now being prescribed by nurses. When it started, you know, the Commissioner of Clinical Services, who had just retired, was my classmate, Dr. Mandua. They wanted to throw him out of the ministry. How could you allow nurses to prescribe morphine? But nurses are doing it, and there have been no adverse effects. So it sometimes takes that leadership, someone to put his or her head on the line and say this can be done, and it will be done under the following kind of situations. Otherwise, the status quo tends to reject any type of innovation or change that will bring up any progress.
Thank you. Do you want to comment on that?
I think I made quite a few points earlier, but I think just two things to follow up. Health system strengthening takes time. It's not an overnight thing. And I've been talking to several people today, and you know, they've been saying that things are a bit slow, etc. And health system strengthening takes time. So don't think you can just do it overnight, and don't get discouraged if it's taking you a while. The other thing is just to kind of add on a bit in terms of palliative care and the Ebola crisis and palliative care within humanitarian situations. The Ebola crisis really made us as palliative care practitioners sit up and say, hang on a sec, we've not been talking to our colleagues working within humanitarian situations, and yet one of the, palliative care would have been in some ways an obvious specialty to have involved in the Ebola crisis. But we've not been there, we haven't been at the table, so we're beginning to work and trying to get palliative care at the table for some of these other humanitarian situations as well.
Thank you. Comments? I'm sure there's a lot of experience from the floor. Any particular comments on any of the points raised, or anything from today about some key messages that you think we should take home from now? Yes. Microphone, do we have a microphone?
I was really interested in your talk about leadership and how important that is to develop that within your health system. But I wondered whether that's something that we can really teach on a course, and in fact whether we do that particularly well in our own health systems in the UK a lot of the time.
I think we could get into discussion, is leadership something you learn or something you're born with, or but I think yes, I think the key thing for us was that yes, we were kind of teaching it, but we were modelling it, and we were working alongside and providing that mentorship and being there as a safety net, so that when the nurses did step out and try and manage conflict or try and do what they hadn't previously been able to do, we were there to talk through it with them and support them and help them to learn. I think the nurses who we were working with were probably self-selected in terms of they had an interest in some basic leadership skills. They just needed support and encouragement and that ongoing development.
So the mentorship was really probably the larger portion of
Mentorship was really key. The other thing that we did was every day when they were in class, we had somebody come and share their leadership journey. So we had Harriet Mayanja, who was the Dean of the Medical School at the time, share how she had got to being in that leadership position. We had some of our UK mentors share. One of them shared how she started off as an enrolled nurse and then became a registered nurse, and just sharing their leadership journeys so that they were able to see that it is a journey and that it's a process. So I think that was quite important.
Can I just make a few comments on that as well? My observations in Sierra Leone, we were working with an NGO. The NGO had their own clinical leadership structure, which was sort of working alongside the volunteer group from UK Med. It wasn't an entirely happy relationship at times. From my own perspective, I've spent 5 years leading anaesthesia and critical care across the whole of North Wales. I've done quite a bit of management training. It was quite obvious that the leadership from these people, whilst they knew a lot about infectious diseases and tropical medicine, they knew very little about leadership. They had no proper leadership structure in place. And the thing they really did not do, and I tried to do it sort of behind their back or despite them, was to empower the local staff in the teams to take leadership of the shifts and allocate the duties amongst themselves. And instead of us giving the handover between shifts, getting them to do it and to try and build their skills. And this was very late in the process, and I think we missed a big opportunity there. And I think the other NGOs probably generally need to start thinking much more about how they empower and develop leadership skills amongst local people, rather than doing it for them, enabling them to do it for themselves. That's just an observation with one NGO, but I suspect it was replicated in other places as well.
Just a comment.
Specifically on your question, when you have a well-functioning system overall, whether there are gaps in leadership or not may not be so critical. And you could even take a lesson from the general political leadership. You may change prime ministers every 3 months. Everything is normal in the UK. In certain countries, you go for 8 months after elections when there is total chaos, because the systems are very weak. So in the setting of weak systems, leadership is so critical. But when the systems are sound, you may put anyone in a leadership position and things will go on as
Any other comment? Just a bit of a comment on that. I think some of us have been involved with NGOs that come from there. I think we say when we do partnership, we ask people what they need. This thing of challenging about the way things have always been done is actually a very critical part. Because I know when we started a maternal and child health program in Bulawayo, we knew that there had been a program that had been running for many years, that in the whole country had been for 4 million. But that program always sent matrons to a hotel, they got trained and they came back. We tried to introduce a program where we were training midwives at the hospital without paying them per diem. And for the first time, it was very difficult. By the second and third time, it was very successful. Even the matron came. But we also identified within the midwives, not the matrons, key 2 midwives who are still leading the program in the whole region in Zimbabwe. But it also takes, to some extent, I know that having somebody like me, a bit of a diaspora, can be able to help. I'm not saying all diaspora help, but there is an element sometimes of that being there. But you need to challenge system rather than say we do what they want. Sometimes what they want is wrong. We're talking of a colleague that we know very well from Zimbabwe, who a few years ago was completely opposed to clinical officers. Now he's converted, but it's because he's making the decision. So we want to be able to find ways of challenging people. Any other comments? I know Tony will tell me when time is running out.
Gentleman Cameron, I'm sure there must be very many cultural pitfalls that you can fall into when you're teaching and training people about leadership, because different cultures have different ideas of what constitutes a good leader, whether it's power, whether it's diplomacy, whether it's kindness, or whether it's gentleness. I know, Zed, you've given fantastic talks before about cultural mismatch in these situations, but I just wondered if Julia had any thoughts about problems, trying to work out what constitutes good leadership in a different country?
Yeah, I mean, that is a challenge, and we tried to be quite open about that, and we had discussions amongst the team, trying to find out from them, from the nurses, what did they see as a good leader, trying to give us examples of who they saw as a good leader, what were their leadership skills. And we looked at some of the literature that we shared. We always tried to talk about it within the Ugandan context. I think, having been in Uganda since 2001, I've picked up quite a few things, but by no means am I fully aware at all about the culture. I think the longer I'm there, the more I realise I'll never understand the culture. But at least we were able to bring that into effect, and a lot of the leaders who came and shared their experience were Ugandan and were able to share their experiences. I mean, one was quite a simple thing, and this was Harriet Mayanja. She introduced a room where people could breastfeed their babies, and it made such a difference to returning mothers. It enabled them to stay at work. She got quite a lot of stick from some of her colleagues, but actually the difference that made, and that was something that she was able to share as a Ugandan, and something that she had put into practice. So we did try and draw on the Ugandan experience where we could.
Any other comments or experiences? I know there's a lot of links here that they've done fantastic work in terms of any problems with disability, cultural issues. I know Paul is itching to say something there, or anybody else. Yes. Mike?
Sorry, this is for Julie. Julie, sorry. And I've done my PhD in Uganda, and I'm quite familiar about Ugandan health workers. And I'm curious about how, when you do the training for the nurses, and often you've got a lot of problems with the lack of health workers in Ugandan health settings, and who fills their gaps, and how do you make sure that the healthcare provision goes on while the nurses are attending the training? Just an ethical question for me.
Yeah, that's actually a key issue, and again, a couple of our nurse leaders, when they first came down, they said, we are concerned because who's going to see our patients? We are the palliative care people. So then we were working with them about actually exploring that perhaps it's not good for palliative care just to rest on the shoulder of one person and to train up other people. And by the time they came back the next time, they had trained up people, and palliative care was still happening while doing that training. And that is a big challenge, and we have that particularly in children's palliative care. There are so few people working in children's palliative care. If we want to do training, we're taking away those who are providing clinical care to do the training. So how do we balance that? So I think that's an ongoing challenge.
There was another, yes? No?
Maybe more of an observation really than a question, but I am involved in an organisation that trains midwives in Ethiopia, and one of the frustrating aspects of our work is that you do training with healthcare workers, and then you go back sort of 6-12 months later and find that all the staff have changed, they're different, and so then trying to strengthen healthcare systems can be very challenging.
Yeah, I mean, we had, so I was working initially at a place called the Malmö Centre, which trained for HIV, and we decided we were going to be very positive. You know what, if we train people and they left Malmö, great, they're taking their skills elsewhere. And so it's about trying to encourage people when we're training them to utilise their skills in whichever setting they're working at, and thinking about we're trying to build capacity within the health system, not just within our own little part of the health system. And yes, you then have to retrain people, but it's an ongoing challenge, and we're trying to build the health system. So if people who we've trained can go and work somewhere else and build capacity there, then that's great as well. So it's trying to look at it in a positive way.
Yeah.
Sorry, Julia, it's a question of you again. I just wondered, in the African health system, do you see a role for village health workers in palliative care? And if you do, what is it?
Again, initially saying all of the health systems are different within different countries, but yes, we have different countries use community health workers, community volunteers, different names. They're just reintroducing a new CADA in Rwanda, who are all going to get training on palliative care. So we try and do sensitisation around palliative care at all levels, so that we have the people, the village health workers, or whatever they're called, who are aware of what palliative care is, so then they can, if they see somebody in their community who, for example, is in pain or has symptoms that need managing, they can tell somebody. So we try and do some training at all levels. In Namibia, we had a whole program that was being run by community health workers because there just weren't enough nurses. So yes, I do see a role. And we talk about making palliative care accessible wherever the individual is, and that might well be in the village, it might be in a hospital, it might be in a health centre. So how can we make sure that they have access to palliative care?
Just a comment, I'm a big fan of village health workers. I think they can do everything. My final year project was on village health workers and I got a prize. There was a big conference on neonatal mortality from Bangladesh, and one of the big impacts of why the neonatal mortality went down was related to the village health workers. Just because they went there, they managed to discover this baby. So there's a huge role, in my view, for every particular area. But obviously,
at the height of the AIDS epidemic in Uganda, a lot of the terminal care was offered by counsellors who were lay people identified from the communities. So you could say they were rendering palliative care. So there is already within the Ugandan context experience of using community or village members from the village teams to render some of this care to terminally ill patients. And this was a time before the ARVs or any other form of treatment was available. So yes, the people can be equipped to render this kind of care.
One last comment on the floor, I think.
Just on the back of that, I have a project that I'm linked with. It's not my project, but also in Tanzania, where I'm based. This person has trained, or this project has trained a lot of, I suppose, village workers, but they're termed the home-based care team. And they were originally trained 10 years ago to do palliative care, and a bit more than that, much more broadly. They're not health professionals at all, with HIV. In that particular community, because they were so successful, this particular project has now retrained that exact same workforce, because there's no particular need of palliative care for HIV in that particular community. And the same people are just sort of being redeployed for non-communicable diseases, for wound care, for diabetes and other things. And they're using their skills they learned doing the HIV palliative care, or home-based care, broadly. And I think that's very innovative, because the people and the skill set are there, all that experience, all that interconnectedness, because they're all from those communities. And I think it would be, I don't know of any other projects where similar has been done, but it's very, very effective actually.
Thank you. Tony, I think that was very good.
Okay, just thank you very much to Zed for chairing that, and thank you to the panel for contributing. Just want to make a couple of thanks in terms of closing the conference.